Hello, everyone, and welcome to our live session today. Just before we begin, I will be going over a quick startup presentation to welcome you all and introduce you to our program and opportunities if you have, of course, not previously attended one of our shadowing sessions. I do want to highlight that Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources not matter their demographic status, abilities, or location. That's very important to us. My name is, of course, Jesus Alvarez. I am the co-chief of program planning, and I will be leading you through this presentation. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your screen. And if you need assistance enabling the transcript, please direct message one of our team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations whatsoever for how we can improve, you can email us at info@prehealthshadowing.com. So since this is an international program, we want to know, where are you guys zooming from today? Drop it in the chat. I want to see where you guys are coming from. Okay, wonderful. I myself am coming from the Caribbean, from the island of Puerto Rico. Great. Oh, wow, that's wonderful. Thank you so much, guys. So if you want to stay in the loop, follow us on social media. We are active on Instagram and TikTok, or you can sign up for our email list on our website to never miss a session. We also want to highlight that we have some wonderful opportunities for you all as benefits of being part of this amazing program. We have partnered with Kaplan to get students a 10% discount code that can be used on all Kaplan products, as well as free resources such as study guides to help prepare you for standardized tests like the MCAT, the NCLEX, or the PCAT. If you fill out our short survey in the chat, we will get signed up for these deals for free. We would also like to draw your attention to another amazing program that is Neolith right over here. This is an online mental health platform for students. College and young adult life is stressful enough as it is in non-pandemic times. For pre-health professionals especially, we know that the path isn't easy. That's why we have partnered with Neolith to spread the word and offer free access to the services if you use the link in the chat or enter the code PREHEALTH when signing up. So keep that in mind, you guys. Another amazing partnership that we're dealing with is Mask for Mask, which is an amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic. For example, those in the homeless communities, healthcare workers without the proper equipment, and others who are struggling to stay safe. With our discount code PHS15, you can get 15% off your order. If you buy through this method, Pre-Health Shadowing will also get 10% of the proceeds, which is of course amazing because, as I mentioned earlier, we are a nonprofit that runs solely off of the support of our community. If you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be a part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and a lot more, guys. We understand that, of course, as a pre-health student, you may not have the time. So we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would love to have you be part of this program and contribute your own unique perspective. So, you might consider it. Also, if you're a high school student and you want to get involved, I'm really sorry. We have started a program called HTP, which stands for High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through pre-health shadowing. We, of course, want to recognize the hard work of all of our students in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link dropped in the chat to have your work on our website. This will look definitely great on your CVs, applications, resumes, etc. So do take advantage of it. Part of our mission at PHS is to promote diversity, and in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and international student forum. If you have a mentor, professor, or professional that has inspired you in any way and you think they could contribute to these conversations, nominate them today using the link that was sent in the chat. If you can, we humbly ask that you donate to our program. As you know, the health shadowing is completely student run and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. Throughout this session today, we encourage you to drop any questions you have for the speaker in the chat. Our team members will make note of these to be asked in the latter half of the session. Also, take good notes as our professional is going over the presentation, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of this session, so stay tuned. Lastly, if you can, we request you to turn your cameras on. This is by no means an obligation, as we are respectful of different circumstances that may arise, but it does help us feel closer together in a time when socially distancing is, unfortunately, mandatory. Once again, I appreciate you for listening, and now I would like to welcome our professional. Thank you so much for joining us. You may share your screen whenever you are ready.
All right, can everyone see my screen?
Yep.
Yes.
Awesome. Thank you guys so much. Thank you for the introduction. And thanks to PreHealth for the opportunity. So my name is Alex. I'm a neurosurgery resident, and I'm going to take you guys through a little introduction about what neurosurgery is like, how I got into the specialty of neurological surgery. And I'll run you through a quick case presentation to give you a brief taste of what our day is like on a daily basis. So let's get started. So like I just said, my name's Alex. I'm a second-year neurosurgery resident at Mount Sinai, which is the largest health system in New York City. For my undergraduate education, where most of you are at currently, I went to Johns Hopkins University in Baltimore, where I studied neuroscience as well as psychology. I know there are a lot of psychology majors in the room, so props to you guys. When I was at Hopkins, I played varsity baseball. I was a pitcher. I was very involved in student government. I was a student body president my senior year. I really loved being part of impacting student life and making initiatives to better life on campus for all undergraduates. And then when I wasn't either on the baseball field or in the boardrooms for student government, I was at Johns Hopkins Hospital participating in trauma and neurosurgery research, which I'll talk to you guys a little bit about later. And then for medical school, actually when I crossed the country, I left the East Coast for the first time and went over to San Diego to go to UC San Diego School of Medicine. I had a great experience and I really developed my love and interest for neurosurgery. And then nowadays, now as a neurosurgery resident, I obviously spend most of my time in the hospital, but when I'm not either in the operating room or taking care of patients, I'm really active. I enjoy working out, participating in CrossFit, hiking, snowboarding. I like traveling. Obviously COVID has affected that, but I have some travel plans coming up and trying to do my best to see the world. And yeah. So when I'm not treating patients directly, I do love participating in research. Research is really important in the field of neurosurgery. And my clinical as well as research interests are in complex spine and deformity surgery. I also have an interest in treating malignant brain tumors like glioblastoma. And I also have an interest in pediatric neurosurgery. So just to give you guys an idea, I'm sure many of you have a vision of what neurosurgery looks like, but I just want to start from the very basics and define it for you, and then explain to you what our field entails and to give you a sense of why I went into it and why you should be interested. So as it may be pretty self-explanatory, it's the specialty that pertains to the surgical treatment of the nervous system. Now, most people think the nervous system is just the brain, but really when you break it down, the nervous system is both the brain, the spine, and the peripheral nerves. So if you look at the picture on the right, almost it kind of looks like your whole body, doesn't it? So wherever your body is your nervous system. You actually have more nerves going into your gut than you actually do in your head. Your whole body is your nervous system, and because of that, any pathology of the nervous system that requires surgical treatment, we are responsible for. Now, just like many other specialties in medicine, we are divided into many subspecialties. So this is a list of the majority of the subspecialties in neurosurgery. I would say by sheer volume, most of our procedures are actually extracranial, or not inside the head, but actually of the spine. About 70% of neurosurgery pertains to the spine or the spinal cord, where we perform everything from minimally invasive surgery through a tube just a couple millimeters wide to these large complex deformity surgeries on patients who have conditions like scoliosis. Additionally, neurosurgical oncology includes treatment of tumors of both the brain as well as the spine. Skull-based surgery can include everything from taking out pituitary tumors, where we'll go through the nose and remove a tumor from the anterior skull base, to middle fossa tumors, tumors that involve nerves that control your face and your ability to hear, like acoustic neuromas. And then cerebrovascular is a huge specialty within neurosurgery, where we treat everything from strokes, aneurysms, AVMs or arteriovenous malformations. Pediatrics is self-explanatory. It's the treatment of children who have neurological diseases and disorders that require surgery. Functional neurosurgery is a rapidly growing subspecialty in the field that includes treatment of movement disorders, mood disorders. So historically, if you guys have heard DBS or deep brain stimulation, that was initially popularized in for use in disorders like Parkinson's disease or dystonia. However, now we've broadened the application to mood disorders, such as depression or anxiety disorders. So it's a really exciting field to see where functional neurosurgery is going and how it can modulate your mood or your actions. And then finally, peripheral nerve is a big field as well. As I mentioned before, you have nerves going into your hands and your feet, all over your body. And so you can develop tumors or lesions of some of these peripheral nerves that can require surgery. And as neurosurgeons, we're responsible for these conditions as well. So this just shows you some pictures here. So in the top left, that's a malignant brain tumor there. The bottom left, that's a scoliosis correction, where you can see the big S shape of the spine. And once we instrument it, we can straighten out the spine again. And then the bottom right is a cartoon of an AVM of the brain. So there are a bunch of misconceptions of neurosurgery. A lot of people think they know what it is. It's often misconstrued in the media or in television. So I just wanted to address some facts about neurosurgery and then address some misconceptions that people often associate with neurosurgery. So to start out with what neurosurgery is, we're a very diverse field. As I just mentioned, there's a vast amount of subspecialties where we treat everything from a neonate who was just born, who has a condition like myelomeningocele, to a 90-year-old who has a subarachnoid hemorrhage from a ruptured aneurysm. We really run the gamut, and we treat all patients with many different types of pathologies. Technically, it's very challenging. As you could imagine, we're operating in some of the highest priced real estate in the entire body, between operating in the brain and in the spinal cord. So it's very technically demanding. Because of this, it takes many years to train to be a competent neurosurgeon. There's a very strong research component to neurosurgery. Because we're a very small specialty, by number of residents we accept every year who matriculate into neurosurgery, we are by number one of the smallest specialties in medicine. And because of that, we look for innovators in the field, people who are willing and able to move the field forward and to really bring the field to a place beyond where it is when they enter it. It's an incredibly rewarding specialty. It really epitomizes the high risk, high reward cliche, if you will, and that because we're operating on such high price real estate, when you're able to safely make a difference and improve someone's life, there's really a large responsibility that comes with that. And because of that, our patients are incredibly grateful that we're really able to make a huge impact and totally change the direction of someone's life. And then, like many other surgical specialties, neurosurgery tends to be one of the more well compensated specialties. Some misconceptions about the field, and I just want to address. There's a misconception that all neurosurgery patients have bad outcomes, or that they're comatose, or people like to use the term vegetables. However, this is by and far not the case. There is the occasional patient that may have a bad outcome or may have a poor prognosis. However, the majority of our patients do very well, and they end up recovering well from their conditions. Again, there are always exceptions to this, but if you look at the majority of our patients, most of our patients do very well and have good outcomes. It's also a misconception that you have to be the top medical student at the top medical school to become a neurosurgeon. If you're not number one in your class at Harvard Medical School, you can still become a neurosurgeon. I know neurosurgeons who went to osteopathic or DO schools, who went to Caribbean medical schools, who went to foreign medical schools. At the end of the day, it's not as important the name on your diploma, but how you got there and your work ethic and your aptitude are really important, and your drive to become a neurosurgeon. If you're willing to put the time and the effort in, you can do it in our specialty. I've seen it time and time again. Going off that line, there for some reason is this horrible misconception that women can't be neurosurgeons. Like many other surgical subspecialties, neurosurgery is a male-dominated field. That's really historical and something we're actively changing. Unfortunately, it still exists today that only 7% of neurosurgeons in this country are female. However, that's something that we're actively working on. Every year, we're recruiting more and more women into neurosurgery. And that goes for minorities too. We have a horrible disproportionate amount of African Americans and Hispanics and Native Americans in neurosurgery. And this is something that we're actively doing. I can speak from Mount Sinai standpoint that we're always proud to bring in more and more minorities. Of our incoming class, one of our 2 residents is African American, and we're really excited to have him and to increase our number of minority residents in our program. So it's something that we're actively working on, and I know that on a national stage, the field of neurosurgery is working on as well. And finally, it's not Grey's Anatomy. We don't all live the McDreamy life, even though it is fantasized a little bit in this show. We do work very hard, and we don't spend all day just messing around. So it's definitely not exactly the case. So just to take you through how I got to where I am now. So I actually started in Philadelphia, where I was born and raised. And then I went down to Baltimore to go to Johns Hopkins for college. Then quickly left the East Coast to go out to San Diego to start medical school. And then made my way all the way back to be closer to family and friends here in New York City. See, a lot of you are from New York. So big shout out to my Big Applers. So I'm here at Mount Sinai, which if you're from New York City, you're very familiar with our health system. All right, so if you guys don't have any burning questions now, again, we'll have time after for questions, I promise. I'm going to give you guys just a very quick lesson on one of the basic pathologies that we see in neurosurgery, especially in neurotrauma. And the reason I want to bring this case up is because even if you don't go into neurosurgery, or even if you don't become a physician, you become a nurse or a physician assistant or a tech. This is something that you're going to see, and as a member of the healthcare team, intracranial pressure management is something that you're going to actively be a part of. So I want you guys to all take some notes and take some lessons from this. So I want this to be interactive. I'm going to keep the chat up on the side of my slides. So I really want you guys to participate. I'll give you guys some questions. Feel free to just type in your notes or type in the chat box. I'll give you guys a couple seconds to answer because I want to see where your guys' heads are at. And that will gauge the conversation as well. So just to create a little scene, we have a 35-year-old guy. He's brought in by paramedics after a high-speed motor vehicle collision going about 75 miles an hour. No one saw the crash, but when paramedics got there, he was mumbling, confused. He vomits non-bilious, non-bloody emesis, or vomit twice. So these are his vital signs. I'll just tell you guys, overall, this is pretty normal. He doesn't have a fever. He's a little tachycardic, but after a big trauma, this isn't abnormal. You're going to have some adrenaline going, so some tachycardia is within normal range. His blood pressure looks okay, and he's satting decently well. So what's your guys' next step? So you get a page, you get a call from the trauma bay. Hey, we have this guy. He just came in. This is what's going on. What's the next thing you do? So just feel free to type in the chat box. Okay, I'm seeing a lot of scans. Everyone's rushing this guy to the scanner. Assess cranial nerves. All right, so some really good answers. Okay, I like it. All right, so it's kind of a trick question, but with any case like this, the first thing, the reflex answer is you have to see the patient, right? You have to see the patient. There's no substitute for getting a good physical examination, okay? So the first thing you say is, thanks for the call, I'll be right there. And you rush down and you see this patient, right? Because this is a big high-speed trauma. This guy could be really sick. We have to see this guy. So we go ahead, and even though we're going to do a full physical examination, as a neurosurgeon, I care the most about the neurological exam, right? I do a very focused exam. I trust that the trauma doctors are listening to the heart and lungs, make sure that he doesn't have a big pneumothorax and that his heart's beating. I can look at his vitals on the screen. I already know his heart's beating based on his heart rate on the monitor. So I get a neurological exam, and this is what I get. So his eyes are open to noxious, which means that when I rub him, give him a nice sterile rub or pinch him a little bit, say, hey, Mr. Smith, wake up. He opens his eyes. He's moaning, but he's not really making normal words. He's not having a conversation with me. His pupils, the right pupil is 4 millimeters and sluggish. The left is 3 millimeters and brisk. Now, quick question, just yes or no. Do you guys think this is a normal pupillary exam? Is this normal? Okay, lots of no's, good. This is not normal. So actually, people can have unequal pupils. You can have something called physiological anisocoria. It's rare, but it can happen. However, the fact that one pupil is reacting briskly and the other sluggishly is not normal. This should be a huge red flag for you that the pupils aren't reacting the same way when you shine a flashlight in them, okay? This is called the pupillary light reflex or light response. And the normal response is a brisk constriction with light. Okay, he does have a cough reflex. He does gag when you stick a tube down his throat, which is all normal. So Julie asked a great question. Could that indicate what side of his brain this could be affecting? Absolutely, and we'll get to that in a sec. So he's extensor posturing in the left upper lower extremity. So what that means, if you guys haven't heard of this, is when you stimulate him, or even sometimes when you don't stimulate him, his arm reaches out and it pronates. His hand comes in like this and his leg extends, okay? He extensor postures. I'll just tell you that's not a normal response, okay? That's an indication that there could be some compromise of the brainstem, okay? He's moving his right side spontaneously. He's wailing it around, moving it however he wants, and he's not following commands, okay? So this is a very concerning exam. Now, if you guys see at the top there, I say GCS 8. Now, is GCS 8, do you think it's normal, abnormal? Is this mild, moderate, severe? How does this fall in terms of how normal or abnormal this GCS is for you guys? But let me ask you a better question. What's the normal GCS? You guys are so smart. 15, exactly. Let me see, do I have it next? Yeah, perfect. I don't even need to give this lecture, you guys know all the answers. All right, so 15 exactly is the highest GCS. If you haven't fallen asleep to this lecture already, you guys are a GCS of 15, so congratulations. If you're asleep, then you're probably a little bit lower. But GCS of 8 is very low. It's actually considered a severe traumatic brain injury. Moderate traumatic brain injury is GCS of 9 to 12, and mild traumatic brain injury, or like a concussion, is GCS of 13 to 15. Okay, Nina, nice. Throwing out some GCS definitions for us, I love it. All right, so we get this exam, very concerning. What's the next step? Isabel already answered it, so I don't even need to ask the question. So great question, Shimanji. So GCS, 3 components. They're actually on the screen. Eyes, verbal, motor, okay? So that description of his neurological exam sums up the GCS right there. Eyes are what if he opens them spontaneously or to pain or to speech, or if he's just spontaneously opening his eyes. Verbal, you can see there, depends on if he's speaking, making words conversationally, if he's oriented. And then motor is if he's following commands, bristly, if he's anti-gravity, or if he's posturing. So the next step, yes, is he needs to be intubated, okay? One of the big take homes I want you guys to take home from this is that ABCs are always the most important. Even though this is a neurosurgery lecture, we're doctors before anything else, okay? I can't take this guy to the operating room if he's not protecting his airway, right? If I don't stick a tube down his throat and mechanically ventilate him, he's never gonna make it to the operating room, right? So it doesn't matter what's going on inside of his head. If we don't prioritize airway, breathing, and circulation, or I know now they've changed it, breathing, airway, circulation, then it doesn't matter, right? So you always have to think top down in terms of emergency management. Again, this applies regardless of what specialty you guys go into. So we've secured his airway, we've sedated him, he's intubated. Now we're controlling his respiratory drive, and now we get the CT head that you guys wanted so desperately. Sorry, quick question. So what exactly tells you he needs to be intubated? So his GCS, his alertness, his consciousness scale tells me with a GCS of 8, the trauma guidelines, and there's actually very good evidence now to support this, you're not able to adequately protect your airway with a GCS that low. So the trauma guidelines say if your GCS stay or below, you have to intubate the patient. That's a no question situation. Can I intubate the patient as a neurosurgeon? Can I? Yes. Should I? No. Just being 100% honest. It's not my specialty. If there's no one else there and he's crashing and needs airway, yes, I would intubate the patient. But realistically, I'm not the person. In a trauma setting like this, there are like 20 people there, right? There are emergency medicine doctors, there are anesthesiologists, there are critical care doctors. There are people much more qualified than me to intubate the patient. I've intubated a couple of patients, but really it's not appropriate for me to be the one intubating the patient. So realistically, just in practicality, someone from the emergency medicine team or anesthesia team would be intubating this patient. So we get a CT head, and this is what it shows. So while I'm answering Jose's question, why don't you guys tell me your diagnosis, and then we'll see how you do. Is there a point in time it would be wise to intubate the patient even with abnormal? Do you mean with a normal GCS? So typically for a GCS, 8 or less, we're going to intubate the patient. If it's more than that, or if they're aspirating or they're not protecting their airway for another means, then we'll intubate the patient. Okay, so brain lesion, it's not very specific. So I'm teaching you guys how to be neurosurgeons. You have to be specific. I don't want to know that there's a lesion, right? Lesion could mean that there's like an infection or a tumor in the head. What is this? Okay, a lot of subdurals. People like a subdural hematoma. Brain swelling, okay. Subarachnoid tissue causing pressure, all right. Midline shift, all right. You guys like subdurals, okay. All right, good. So you guys already said the diagnosis. So yes, this is a subdural hematoma. Now, since you guys are so smart, what we do in medicine is we just keep asking you questions until you get some wrong. So because you guys are so smart, why do I know this is a subdural and not an epidural hematoma? Okay, but you can't see the dura on this, right? So I'm just, picking your brain because you guys are so smart. I'm going to challenge you. So you can't see the dura on the CT scan. So how do you know it's inside the dura? So the shape, Belinda, exactly. But where does this bleed go that I know it's not an epidural hematoma? It's okay if you guys don't know. It's a tough question. So not gyri, but you're close. So the bleed crosses suture lines. So you have cranial sutures that when you're a baby, they're open, which allow your cranial vault to expand because your head grows actually very quickly as a baby. But when you're old, by the time you're three years old, all your cranial sutures fuse. And so actually tense up the dura in those regions. And so if it's an epidural bleed, the bleed can only expand until it hits that suture line, and then it can't cross sutures. However, if it's a subdural hematoma or a bleed in the subdural space below the dura, then it's not restricted by the cranial sutures, and it will expand through the whole hemisphere, as you can see here. So I can tell you, I don't think you guys can see my mouse. Tell me if you can, but the coronal suture, I know, oh, you can, perfect. Coronal suture is gonna be about here. You can't see in this cut, but you just know based on anterior posterior that the coronal suture is gonna be around this level, okay? So because of that, I can see the bleed is clearly going above and below it, or anterior posterior to it. So that's how I know it's crossing suture lines. All right, so you see this bleed, right? I will tell you, it's a large right-sided. It's right-sided because the orientation of a CAT scan, the left side of the picture is actually the right side of the head. It's a large right side hematoma, and there's a lot of midline shift. You guys were perfect with that. So what do you want to do next? So you guys are the neurosurgeon. So I say, Dr. Amy, Dr. Julia, what do you guys want to do? I have this patient, this is the scan. I already have them intubated for you. What would you like to do? Okay, so I like consent. You always have to consent the patient. You're not going to consent this guy. You're going to consent his family. Okay, people want to drain the blood, burr holes. Okay, burr holes, burr holes. Okay, improve the pressure. I like it. All right, so people want to operate. That's good. I'm glad you guys want to operate. This is a surgery talk. So let's go back to the basics. Let me keep track of time here. All right, 8:30, perfect. So if you're going to take one thing away from this, besides the ABCs, this lecture, I want you to take home this slide. I don't care that you guys remember, that's called the Monroe-Kelly doctrine. What I want you to remember is the relationship between pressure and volume. Now, you guys have all taken a science class before, otherwise you wouldn't be here. So you can think of the skull and the cranial vault as a closed box, okay? There are only three things inside this box. They're blood, water, or CSF, cerebral spinal fluid, and the brain. There are only three things inside, okay? And they're at a fixed volume, or a fixed number of things, of contents. As you increase the number of things inside this fixed volume, the pressure is gonna go up, right? Very simple relationship between volume and pressure, right? In a fixed volume, you put more things inside a fixed volume, the pressure inside of that volume will go up, right? Now, for the next 10 slides, that's all you need to know as far as how we manage intracranial pressure or intracranial hypertension. Okay, so the reason ICP matters is because of something called herniation. Now, have you guys heard of herniation before? Or is this a new word? If it's a new word, just let me know. New word, perfect. I love it. Awesome. So I want you guys to look at the first 6 letters of that word. Have you heard of that word before? Yeah, right? Exactly. So what's that? It looks like that, right? What is that? That's a hernia, right? That's umbilical hernia. Okay? The same thing that happens in your belly happens in your head. So what's a hernia? Essentially, it's just a piece of your body or some matter penetrating through a space that's not supposed to be in. Okay? That's what a hernia is. Okay? However, instead of umbilical hernia where your bowels come through, this is where your brain is actually herniating or going to another place that's not supposed to be in. And so this is why ICP is such an issue. Because as you can see from this cartoon here, your brain can actually herniate in many different ways due to increased pressure or due to an insult. As you can see here, there's a little bleed or a little lesion on the left side, which is causing the brain to push down. Now, why is it a bad idea if your brain pushes down? What's down there? When your brain goes down due to pressure, what is it going to push on? You guys are so smart. The brainstem, right? And what does the brainstem control? Everything that you care about to survive, right? Breathing controls your ability for your heart to regulate, all of your autonomic functions, right? All the things that really matter. The most basic things you need to survive are controlled through your brainstem. So if you don't have a functioning brainstem, you cannot survive. There's no brainstem transplant. There's nothing you can do. Once your brainstem goes, unfortunately, it's game over. So we want to do everything we can to prevent that, okay? This is the big picture. This is why this is such a big deal and why managing intracranial pressure is such an emergency. Because once you get to this point that your brain starts herniating down and putting pressure on your brainstem and stroking out your brainstem, that's it. So we have to prevent that from happening. So this is just a brief slide to show you that there are many reasons to have high pressure inside of your head. We're talking about trauma now and the saying of an acute bleed. However, many things can create high pressure in your head. Everything from different types of infections like neurocysticercosis, tuberculosis, etc. Any type of tumors, even malignant or benign tumors like a benign meningioma, malignant glioblastoma. They can all cause swelling and pressure and elevation inside of the head. Venous sinus thrombosis, all these things can increase the pressure inside of the head. Okay, many things. So when we manage ICP, we manage it from a stepwise approach. We, just like everything in medicine, we start from the least invasive measures and we go all the way up until we have a good control over it. And ICP management or intracranial pressure management is no different. So when we start, there are actually many things we can do to actually decrease ICP before you even have to call the neurosurgeon. And as a medical student or just a student shadowing in the emergency department or trauma bay, there are actually a bunch of things you can do without giving any medications or doing any procedures. So after the patient's intubated, one thing you can do is you can hyperventilate them. I don't know if you guys have ever seen that or heard of that, but increasing the ventilatory rate can actually decrease the pressure inside the head. Now, how does that work? I'll save you guys all the kind of nitty-gritty details, but essentially it affects the pH inside of the head and creates a temporary relative vasoconstriction of the blood vessels, of the arteries going in, bringing blood into the brain. So by decreasing the amount of blood in the brain, it's decreasing the pressure. Thanks, it is pretty dope. Positioning is really important too. Now, the worst thing is when someone calls me for someone who had a huge head bleed and I come down to a trauma bay and they're laying flat. Why is that a big deal? Let me ask you, what happens when you hang your arm all the way down, straight down to the floor, and you hold it there for like 5 or 10 minutes? Right, or what happens if you do a handstand for 10 minutes straight? Your head's gonna feel like crap, right? Because all the blood is pooling there. It's the same thing when you have a head injury. You wanna sit the patient's head all the way up. Why? To encourage venous outflow, to get blood out of the head, okay? It's the easiest thing you can do. If you're a medical student or a college student, you're working in the trauma bay and someone has a big head bleed, get the head of the stretcher and jack it all the way up as high as you can, okay? Because you're just encouraging venous outflow and you're decreasing their ICP. I kid you not, it makes a big difference. When I have a monitor in and I measure the pressure inside someone's head, just by lifting it up, you can bring it down a couple points. Keeping the head midline is super important. How does blood leave the head? Through 2 veins, your internal jugular veins. You have one on each side. By keeping the head midline, what you're doing is you're allowing both of those veins to stay open and allowing blood to flow. If you turn your neck all the way, you're actually temporarily occluding one of those. So you're decreasing the outflow by up to 50%. Potential spine injury. Great question, Amy. You beat me to it. So most of these patients are going to have a cervical collar, right? Because we always keep C-spine precautions. Fun fact, you can still keep cervical strict spine precautions and get their head up. How do you do it? Reverse Trendelenburg. This is the bed. You bring the whole bed like this. That's still maintaining strict C-spine log roll precautions. If they have a spinal cord injury, they can be like this. So that's the easy way to do it. You don't have to just lift the whole head. You can just tilt the whole bed. It's called reverse Trendelenburg. That's the name of the position. Sedation is really important. What you want to do is by sedating the patient. So keep in mind, if you can only do this if they're intubated, right? You have to control their airway or you can't sedate them. It's not safe in this type of patient. But if you're controlling their airway, you can sedate the patient. We often use propofol, like the white milky drug that puts people asleep. We use that to decrease the metabolic rate. The brain is the most metabolically active organ in the body. It uses more glucose per area compared to any other organ. And in addition, unlike organs like the liver, the brain has no ability to store glucose. So it's constantly churning out glucose and energy, and it uses a very high rate of energy. So anything we can do to decrease that metabolic rate will decrease the pressure inside of the head. And then, as you guys mentioned, getting vessel imaging is super important. These are some different types of bleeds. Going back to what I was talking about earlier, guys, the picture on the right, that's subdural hematoma. As you can see, the blood's coming all the way from the whole hemisphere. both from anterior to posterior. Now look at the picture on the left. You guys see the difference of the shape? See how it's that crescent shape? The reason the blood stops where it does is because it's running into sutures. In the front there, it's running into the coronal suture, and then behind it's running into the lambdoid suture. So it's pooling until it gets to the sutures. That's the difference between an epidural and subdural hematoma. Very high yield for you guys when you take your boards in medical school. They will ask you that question, 100%. Does inducing hypothermia have the same effect as well? Great question. The literature actually isn't very good on hypothermia for traumatic brain injury. It's not like the cardiac literature for cardiac arrest, where it's the evidence is actually much stronger for inducing hypothermia after post-arrest. In traumatic brain injury, it's not as good, but some people still do it. It's a little more controversial though. Great question. All right, so next, after we do all that, the sutures. So the sutures are the lines that fuse the cranial plates when you're born. You know how your babies have a soft spot? That's because you have a gap between your cranial plates. They end up fusing. And so the point that they fuse, like your tectorial plates in the earth, are called sutures. All right, so if that all doesn't work, you lift their head up, you hyperventilate them, you sedate them, and their ICP is still high, or their exam is not getting better, we can give some drugs to help take fluid out of the brain. Now think back to that earlier slide, guys, this one right here. This slide here, the difference between pressure and volume, okay? Keep this picture ingrained in your head. Remember, closed box, blood, water, brain, the only three things inside your head. All right, so what these drugs do, the big take home here, is that they suck water out of your brain in the form of cerebrospinal fluid, okay? They really just, they create this osmotic gradient, in the case of mannitol especially, and they create this gradient because mannitol is a huge molecule, and it brings a bunch of water with it, and it takes it out of the brain and into the bloodstream, okay? And it circulates it, and you end up peeing it out. So what that does is it decreases the amount of water in your brain. Your brain is incredibly buoyant. Think of it like a wet sponge. You can actually suck out a lot of water from your brain. So by giving osmotics like mannitol or like sodium chloride in very high concentrations, you suck the water out of the brain and you essentially make it, you deflate it. You really wring it out like a sponge, okay? This is just to show you that in the case of cancer, like a glioblastoma or tumor that has a lot of swelling, you're not going to want to give these drugs necessarily as a sole therapy. You're going to want to give high dose steroids because it's all due to the problem. The problem in malignancy is something called vasogenic edema, or swelling in the associated tissues from the brain tumor. And same with infection, you're going to want to give antibiotics. So just some quick questions here. How you differentiate brain and brains? So that's great. So in pediatrics, the bleeds often come in different patterns. You can still get an epidural bleed. So I'm assuming you're talking about a child, like a very young child, your sutures haven't closed. So you can get like a cephalohematoma, which is a little bit more superficial. You can get a big subdural bleed. It's a little easier to determine when the sutures haven't closed, but you often can treat it the same way. However, it's much easier, as you can imagine, that if the sutures haven't closed, you still have a big hole there and there's some subdural blood, it's much easier to access that because you don't have to go through bone, you have an opening there. Amy's asking, all right, so we'll get to this later. I always feel inadequate every day as a neurosurgeon, I feel inadequate, but we'll get to that later. All right, so the next step, if all of these conservative therapies fail, all the medicine, everything like that fails, that's when people like me step in and we start doing things to help bring the intracranial pressure down really quickly. So how we can do that, you ask, is again, think back to closed box, all right? Blood, water, brain, only three things in a fixed volume, right? So say we try to draw out some of those things and that doesn't work. What else can we do, right? We're talking about pressure and volume. If we decrease the volume, that's one way to do it. If we decrease the pressure by eliminating the number of contacts, that's one strategy. The other strategy is by increasing the volume. Exactly, Isabel, thank you. Even though I was trying to articulate, you answered it. So think about it this way. If we increase the volume, that will decrease the pressure, right? So one of the ways we do that is by doing a surgical decompressive operation. So as you can see here in the picture on the left, what we do is if you have a bleed up here, like in our patient, we can take off basically half of their skull, do something called a decompressive hemicraniectomy. We remove a huge bone, essentially basically half their skull, and we open it up. So what that does is that essentially creates an infinite volume for this pressure that we have, okay? If the bleed is down at the bottom, like where the cerebellum is, we do a similar procedure called a suboccipital craniectomy. It's the same idea as here. We're just doing it at the base of the skull. And then another strategy is we can actually take off cerebral spinal fluid in the form of an external ventricular drain, where we place a tube in, we drill a burr hole through the skull. We place a tube inside the ventricle where the fluid-filled spaces carrying CSF, and we can drain off some of the fluid. And this is a picture of that drain. So we do it at the bedside. The patient can be awake. We obviously will give them some medicine to sedate them, but we drill a quick burr hole. Takes about 15, 20 minutes. We place a tube inside the center of the brain where the fluid-filled space is, and we drain off fluid. Now, that's actually very efficient at decreasing the pressure inside the head. So just finally, in very refractory cases, this is very rare. Usually surgery and other therapies will work. If they don't, and they have super refractory crisis, we can paralyze them, essentially totally decreasing the metabolic demand. And then finally, we can do something called putting them in a barbiturate coma or medically induced coma. This is very rare. I've only seen this, we'll do this maybe a couple times a year. It's incredibly uncommon. It essentially shuts down the whole system. It's like restarting your hard drive on your computer. It is very dangerous. It takes a very long time to reverse. If someone's in a pentabarb coma, it can take them days to get back. So we don't like doing it. We like to be able to examine the patients. And by putting them in a coma, it can take a long time to get them back. So just some take-home points. Intracranial pressure management is something that everyone needs to know if you're going to be working, especially in the emergency medicine setting, which a lot of you guys will be, regardless of what specialty you do. It doesn't matter if you're going to be a nurse, a PA, a doctor. We're all part of the same team. We're all treating the same patients, right? And we're all here for the patient. So it doesn't matter what your role is or what you went to school for. You all have to be familiar with this concept. There are many things we can do that you guys can do, even as undergraduates who are shadowing, say, in the trauma bay or emergency medicine department, to decrease a patient's intracranial pressure before a person like me even comes down. Remember your ABCs, incredibly important. So just some take-home points I want to leave you guys with. Neurosurgery is very challenging. It's definitely a very hard specialty, but it's incredibly rewarding. We deal with some of the most fragile patients, but with high risk comes high reward. It's a really great specialty. Again, we already talked about this. You're always in the brain, around the spine, in the spinal cord. And it's really a privilege to being able to operate on such a fragile part of the body. We're a very rapidly evolving field, and we're always trying new technologies. We now have robots to help us with spine surgery. The new technologies are changing almost every day. It's an incredibly exciting time to be in neurosurgery. And then check us out. We do a lot of really cool things. These are just a couple clips of some cool cases I've done in the past couple months. In the top left, that's a giant aneurysm that we treated through endovascular means. If you look in the GIF in the bottom left, that's a big low-grade glioma that I took out of a young girl recently. In the middle, that's me with my little shark cap, who I was putting on a cranioplasty. So essentially, someone had that procedure well. They did really well, and so we made them and we put it back in. And then the top right, you can see a guy who was a meth user who had a really bad infection of the spine called osteomyelitis, whose spine essentially, so you're already firing away. So I think we still have a couple minutes for it. Thank you guys so much. You guys have been an amazing audience. Just try to post cool cases on my Instagram story, and I try to post as often as I can. So you guys should definitely check it out. I always give like quizzes aimed toward like college kids and med school students, and even some residents. So every weekend I post different quizzes to teach you on like neuroanatomy and different cases I think are pretty cool. So you guys should check it out. And I also have a cute dog named Noodles that if you guys think he's cool, he's a miniature dachshund, so you can follow him as well. All right, so if it's okay with you guys at pre-health, I'll start rattling off on these questions as many as we can. I'll answer you guys' questions as long as you want.
Well, yeah, sure. Like I
So
can just start asking them to you if you want.
yeah, sure. Yeah, go ahead. Yeah, whatever works best. I know there are a ton, and realistically, it's probably gonna be hard to do them all. But Jesus, if you want to just start firing away, we can get after it.
Okay, so the first question is from Nina, and she asks, do DO neurosurgeons practice the same as ND neurosurgeons? If not, what are some major differences between the ways neurosurgery is practiced?
Yes, absolutely. So DO trained neurosurgeon practices the same way as MD neurosurgeon. The only difference is that one went to allopathic medical school, one went to osteopathic medical school. We all received a similar education. Osteopathic has a little different ideology in terms of kind of holistic delivery of healthcare to the patient, but the residency training is exactly the same. So we all practice the same.
Okay, thank you. There's your question, Nina. Your answer, I mean. I'm sorry. Okay, so the next question, it's really interesting, actually. Who were your role models, and did people like Dr. Ben Carson inspire you?
This is a great question. I would say my biggest role model is my dad. My dad's a surgeon, and I grew up in like a surgeon household. Over dinner, I would just hear about all the awesome surgeries he was doing, and it grossed my mom out. But I was so interested and just never wanted him to stop talking about it. And he showed me the amazing things you can do with your hands, and that you can really help people and do good for the world. So he's definitely been my biggest influence. I actually have seen Ben Carson. He overlapped very briefly with me when I was at Hopkins. He's an amazing surgeon. Technically, his skills are incredible. He's done amazing things for the world of neurosurgery. Um, leaving politics aside, he's really done amazing things for the pediatric neurosurgery community. And he has revolutionized how we practice modern neurosurgery. So he's been definitely a beacon in the field, and has really impacted modern age neurosurgery. So he's been incredible. Yeah.
Thank you so much for your answer. So another question is, I think this one's really interesting, actually. I wonder the same thing. Rahil asks, is there any technology that allows for 3D models of the brain when scanned?
Sorry, Jesus, I think you cut out there.
Okay, can you guys hear me now?
I lost my connection. Yeah, I only heard technology.
I'm really sorry. Rahil asks, is there
No,
any
it's okay.
technology that allows for 3D models of the brain when scanned?
Absolutely. So just a shameless plug. If you look on my Instagram, I post a lot of fly-throughs of something called surgical theater, where we merge the CTA or CT angiogram with the MRI, and it creates a 3D model of the tumor or the aneurysm or whatever lesion we're operating on. And I actually show a fly-through model of it. And that's based on the CTA superimposed with the MRI scan. So if you look at my Instagram, I post a bunch of them. And it's all 3D models that we use through a service called Surgical Theater.
Okay, guys, so definitely go follow his Instagram to learn more about that. I believe Rahil wants to ask a question. They have their hand raised. You can go ahead, Rahil.
Oh yeah, no, I was just raising my hand just in case like you were having like I just wanted to restate that you were having like tech difficulties with it. All good though. I just followed the Instagram though. Alex looks pretty dope.
Thanks, man. If you guys have feedback on certain cases you want to see, if you want to see more brain tumors, more pediatric cases, we do a ton of everything in Mount Sinai. So if there's a specific interest you guys have, I'm happy to talk about. If you want to learn more about like medulloblastoma, I can do a post on it and teach you guys something. So I'm always looking for feedback, wherever you guys want. At the end of the day, like the platform is for you guys, it's to be educational and to teach you guys. it's something I do for free for fun. So, whenever you guys are interested in, just, message me or comment on any of the posts if there's something in particular you want to see.
You heard it, guys. Thank you, doctor. So another question from Amy is, were there points in undergrad or med school where you didn't feel adequate of being a neurosurgeon?
Yes, every day. It's one of those tough things. I think this is for medicine in general, that there's always so much to learn, and you're never like the head of honcho, I guess, until you are. So every day you just get beaten down, but it's like the classic saying, like, not how many times you get beat down, but how many times you get back up. And that's really like just medical training in general. And you guys will see, like, when you're a medical student, when you're a resident, there's always someone who knows more than you, and you're never going to feel adequate. And there's high stakes, because at the end of the day, like, you're responsible for someone's life, and you're responsible for treating patients, and that's a huge responsibility, right? Like, what responsibility is bigger than someone else's life? So, if anything, it's just more motivation to work harder and to study more, and to be the best doctor you can be for your patients. And that applies for everything. It doesn't just apply to neurosurgery. Whether you go into nursing or you become an anesthesiologist or pediatrician, like, you should always have that mentality. So no, it's a great question. And just because you feel inadequate doesn't mean you can't do it. Remember that there's always going to be someone who's going to be so much better at something than you, but they didn't start out that way. Like, they put their pants on one leg at a time, just like you do, right? And they started not knowing how to do something too. So as long as you're confident in your ability and you're willing to put the work in, you get, like, it sounds lame, but like, you can do whatever you want, right? And neurosurgery is no exception.
Oh no, I completely agree. Thank you for that. Like, I do believe that as future health professional, or in your case, as already a health professional, our aim should be should be always the patients, right? So another question from Jasmine is, which other avenues or specialties do you consider before deciding on neurosurgery, if any?
That's a great question. I was one of those weird people who actually went into medical school knowing neurosurgery. But I highly recommend, even if that's your situation and you think you know what you want to do, I would still try and convince yourself to enter other specialties as well. It's really important. Medical school, you get to do so much. You get to learn about so many different types of medicine that if you come in closed-minded, you really are missing a ton of learning opportunities. So I pursued a lot of different specialties. I knew I wanted to go into surgery. There was no doubt in my mind. I was only interested in surgery, but I was interested in orthopedics because I was an athlete in college and had my own orthopedic issues. I was interested in ENT or otolaryngology. But what I realized is that the part of ortho I liked was spine surgery, and the part of ENT I liked was skull-based surgery. So that is neurosurgery. So it was very apparent that even when I tried to convince myself to do other specialties, I just circled back to neurosurgery. So it wasn't much of a debate for me. But if you don't know what you want to do, don't fret. That's how 95% of people are, even up until like third year of medical school. And some people even take time off just because they still don't know, and that's okay. It gives you more time to explore and to learn more about your specialty.
Okay, so taking into account you already knew that you wanted to become a neurosurgeon when you entered medical school. Alexis asks, did you shadow any neurosurgeons during your undergrad?
So I did. That's a great question. I shadowed a couple different neurosurgeons at Johns Hopkins Hospital, and um, during summer breaks from college, I went back home to Philadelphia to work on a traumatic brain injury study at Penn at University of Pennsylvania, and I shadowed in the neurosurgery department there. So between Penn and Hopkins, I shadowed a bunch of neurosurgeons just because I wanted to see how it was at different hospitals, to see if my experience at one hospital was similar to another. Um, and I highly recommend that. Get as much of a diverse experience as you can, because every place is going to be different, and you might meet one surgeon who gives off a certain vibe, and that might not be indicative of the rest of the specialty. So don't let one person or one institution dictate kind of your feeling about a specialty. If it's something you really like and there's someone who's just a jerk or doesn't give you the time of the day, don't let that close the door for you. So really give it a whole perspective and try to get as many perspectives as you can.
Thank you. So another member of our audience, following the undergrad topic, asks, how did you learn your learning style, I'm sorry, evolve from undergrad to medical school to residency? So it's like the whole picture.
Yeah, it's a great question. Learning, it can be really challenging, especially as you go from undergrad to medical school to residency, because just the workload keeps going up, right? It never stops. But I think establishing good learning habits is really important. Um, just staying organized and knowing what works for you, and knowing that what works for you or what works for someone else might not work for you, and just repetition, right? How you study in college is really important to get those study skills and to learn what is really effective for you, and then to continue to build on those as you get to medical school is really important. I think maybe we
Guys,
have time for like
do you want to highlight
one more question, maybe.
Oh, sure, for sure.
Is that
I
okay?
do want to highlight, of course, that he said you need to learn your learning styles. So do work on that while being on undergrad. Okay, so for our last question, how does neurosurgery in residency differ from other residencies, since it is so much longer than other residency programs? And when in the residency do you get to start doing operations yourself?
So that's a great question. To answer the first part of the question, every surgical specialty is between 5 and 8 years. So within surgery, neurosurgery is like on the longer side, but it's not much different. Like orthopedics is 5 or 6 years, ENT is 5 or 6 years, plastic surgery is 5 to 7 years. So it's all around the same time. The reason is because there are different amounts of research time dedicated into the program. So we have 1 to 2 ml of operating. When you become more autonomous in the operating room, it depends on the resident, depends on the program. Generally, at least in neurosurgery, by like your third or fourth year, you're doing surgeries on your own. At least the more basic bread and butter procedures. And then when you're chief, or years 5 to 7 is when you start doing more complicated surgeries independently. So it's on a graduated autonomy basis.
Okay, thank you, doctor. And before we wrap up, people in the audience are asking if there is any email or other forms of communication that they can reach you from.
Yeah, sure. Sorry, let me, I will type it right now. All right, so that's my email address. Feel free to reach out to me, guys. Thank you so much again. You guys have been awesome audience. You guys are super smart and you knew basically everything that I asked. So thank you for staying so engaged. Thank you, Pre-Health Shadowing. This was amazing. You guys are an incredible host. I really look forward to seeing you guys, interacting with you guys on social media. And just thank you so much for your engagement. I really appreciate it. I look forward to hearing from you guys.
Thank you so much, doctor, for being our professional of the night. So now, you guys, I will be presenting our wrap-up presentation and get ready to finish this live session. So once again, thank you so much for the informative presentation, Dr. Schüpper. I think we all learned a lot from it. So considering this, I do want to invite you all to reflect a little bit on this live session today. You can follow these 3 questions. What brought you to the session today? What are 3 major takeaways you got from it? And what do you want to learn more about? Or you can do your own reflection in any way that makes you feel comfortable. You can write a little note. You can just answer these questions on the back of your head, however you feel comfortable. And of course, if you're writing this reflection, we do want to highlight that this writing is not required. However, we encourage you to submit it to our website for publication, for recognition of your hard work, for attending, and to enhance your future applications. If you want to learn more about pre-health shadowing and get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic design, and social media promotion. We are also accepting team members' applications if you want to take on a more active role in PHS to lead projects and initiatives to be up here with us. Once again, we are humbly asking that if you are financially able to donate, that you please consider doing so. It costs a lot to keep our program up and running and free to all of you. So if you're someone who can afford to, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you spread the word about pre-health shadowing to reach as many students as possible. Now, for the part we have all been waiting for, earning a digital certificate for the virtual shadowing hours from this session today. The first thing you guys are going to do is go onto our website and find our professionals course pages. Next, you can take our quick 10-question multiple choice quiz based on the content from the session today. You will have 30 minutes per attempt to earn 70% or higher to get your certificate. We know, of course, that sometimes technology can be difficult, and for this reason, we allow up to 2 attempts to take the assessment. But if you run into any difficulties, please do not hesitate to contact us. To ensure that our website does not crash from a high influx of students, we recommend waiting 30 minutes to an hour approximately after this session to take the quiz, which will be open, and I will highlight that, indefinitely. Once you have passed, you can click the Finish Course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. If, unfortunately, you missed a part of the session or you want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for these as well. Be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming sessions and events. We are currently booked every single weekday through June for virtual shadowing sessions, so we definitely hope to see you guys over there. Once again, thank you for joining us today, and please stick around if you have any questions, and myself and other team members will definitely be happy to answer them. The shadowing session is officially over, and I invite you all to log off and have a wonderful day.